As you know, that the signs of aging are affecting all the 5 layers of the face. We can see in her case that first in the
Em yêu mẹ nuôi ông kỹ quá chi rồi.
support, we have this bony resorption first
Mẹ
here
nuôi
in
ông
the
kỹ quá
temple.
chi.
She has a resorption also in the mandibular angle here and on her mid face. So if we see her on the frontal view, yes, we can see. Look up, look here, please, look here. We can see that she has hollowed temple, lack of projection on her mid-face, and the bony resorption on the bone. Now regarding the other layer that are affected by the aging process, it's not only the bone. You know that the fat is changing with the aging process. So we have some compartments like here on the medial souf, on the deep medial cheek fat compartment. We can see that she lost the volume of her mid-face. But we have other compartments that are increasing in volume with the aging process. And as you can see here, the nasojugal superficial fat compartment is increasing in volume also. Another compartment which is visible in her case, who is increasing in volume and mobile downward with the age, is the jaw. The jaw compartment is increasing in her case. So that was the sign that she is complaining, and we have an explanation with the layered anatomy, and we know that these compartments are changing also in position with the aging process. And the other layer that is changing with the aging process is the skin, of course. So she has also a skin laxity. So this is why, now look here, this is why Linda today looks with signs of aging. She looks also tired because of some shadows that she has in the temple, in the infraorbital area here, and on the pre-jaw. Now, if we look at her on the profile view, we have to think about harmony and balance. And as you can see here, if we improve the projection in her mid-face here, we will have also to think about projecting the chin to have a better harmony with her nose and the lips. So we will need also some projection in the chin. Now, it's also about emotions. So we need to see her and to see her emotion before and to see the disappearing of the shadowings that will lead to a better look, a refreshed look, and you will see that the patient will look less tired. So my target today is to play with the balance of shadows and light on the 3/4 of her face. So I will be starting by improving the mid-face. That will be my starting point, because with improving on the medial souf here and the lateral souf and the deep medial cheek fat compartment, I will get a bony restoration of her mid-face. But if you look at her, she's quite asymmetric. And the lateral cheekbones on her left side is more pronounced than on her right side. So I will need to add other boluses on the zygomatic arch here to have a better symmetry with the other side. And then I will work also with the multi-layering technique to lift and tighten the skin here with superficial injection with RHE4 here. This mid-face projection will help me for two other areas. First, it will improve by lifting the orbital retaining ligament. The second area I will be treating, which will be the infraorbital area. And here I will work with Redensity 2 with the cannula technique. And this mid-face projection will also help me to have a vertical vector to the jaw, because I want to have a lifting effect, not with inflating too much, but just with lifting a little bit vertically this jaw. So that would be my first vector. Of course, with injecting on the mid-face, I will need to harmonize with the temple, otherwise the temple will look much more hollowed. And here I will be using the gunshot technique with RHA4. So as I told you, this mid-face volume restoration will help me for the vertical support, vertical lifting of the jaw, but I will need to stretch this jaw back and also forward, like this. So here I will be using what we call here the Texas technique, which is to better define the pre-jaw and to project the mandibular angle. Here she has this bony support that is lacking now, so I will project the mandibular angle with the multi-layering technique, ultra deep, and then I will be contouring the jawline with RHA4 more superficially. And I want to lift the jaw forward, like this. So my next step will be to contour the mandibular line and to inject superficially in all the pre-jaw area to have this nice lifting effect in opposite direction. And of course, projecting the chin will have also an effect in having a better definition of her contour. So for that, I will be using the landmarks criteria for a female patient. That would be the length of the nose, and here I'll be using a multi-layering technique with 3 deep boluses of Teosyal ultra deep and a superficial retrograding line in her chin. And the cherry on the cake for me today will be to hydrate, to give a slight volume and a nice contouring on her lips, and here I will be using RHA2. So my first concern is always the anatomy. So let me show you the patient before I draw the anatomy. Let's see her on a dynamic way. If you can smile, please. A big smile. Yes. And give us a kiss. Voilà. So we will also work on the perioral lines if we have time today. So let's relax, please, and let's see what are...
Nabila, we have some questions.
Yeah?
Do you think that the sequence of injections is important to get nice result? Where should we start and where should be the end?
In my opinion, the mid-face is always the starting point for me, because as I told you, with giving the support in the mid-face, it can lift the jaw on the lower face, and sometimes we need to use less product than if we started by the lower face. But why not starting by the temples and the forehead, for example? It's just a habit. But the important thing is not to start by the lower face. I always start by the upper layers, upper thirds, and then I finish with the lower third.
Okay, and one more question, thank you. How do you think why the multi-layering approach will be better in this case than one-layered approach?
Yes, because of the aging process, Ludmila, because you see when you assess the deep fat compartment and the superficial ones here, you can see that we have a lack of support. That means that I need to project better, so I will use the deep injection. But she has also a lax and thin skin, and then I want to have this lifting effect to pull the nasolabial, nasojugal fat compartment back here. It's like placing threads, injecting threads of RHA4 to lift back this nasolabial compartment. So I just follow the anatomy and the effects of the aging process and try to restore with the dynamic fillers that will give a natural look.
Thank you. And one more question. What product will you choose for the barcode wrinkles in the perioral area?
For the barcode, since she has thin skin here, I will use a blanching technique with RHA1. And for the lips, I will be using for the contour and the volume RHA2 with the cannula technique.
Thank you.
So here I was drawing the two fixed points of the jaw because it's our main concern today. This jaw has to disappear. So if you pull the jaw forward here, you can see the print of the cutaneous insertion of the mandibular ligament, and here are the multiple premasseteric ligaments. So what we know is that the main anatomical danger is between these two ligaments, somewhere here, but in a deep layer. So here I will never inject in a deep layer, I will stay superficial. And we know, of course, that this facial artery is curvy and then will become more and more superficial. In 80% of the case, this artery is superficial here, but in 20% it can be deep. And what we know, of course, is that this artery will give us the branches for the labial, inferior labial artery, the superficial labial artery here, and of course we will have also the submental arteries with here two ascending mental arteries that are running inside the mentalis muscle. And here again, we follow the anatomy and we know that our multi-layering technique is safe because the first injection points are on the deep fat compartment in the bone, not on the muscle, and the superficial one will be also in the subcutaneous layer and not inside the muscle. So let's follow this facial artery that will give us also all the branches for the nose. And here's the angular artery, and you see that the angular artery is far from my nasolabial groove, and Patrick will show you all of this today. Maybe Patrick will show us also the variation, because we have a lot of variation. The facial artery can be double or can be located within the nasojugal groove here. This is the nasojugal groove where we have always the facial vein. So they can be together, facial artery and facial vein, on the nasojugal groove. That's why here is my first security line. I know that no facial artery will be found up to this line. So in this area, I will not say safe at 100%, but always safer. And also we can palpate the infraorbital foramen here, and that's why my entry point for the infraorbital area will be located upper to this infraorbital nerve. If we go to the temple, I still have 1 minute for the anatomy.
Yes, you have 2 minutes.
So we know that the superficial temporal artery, and Patrick will show you that it's on the superficial temporal fascia. I can palpate it with my 2 fingers, just right here, and I can see also that I have a vein, a visible vein that is also following. So with my gunshot technique, I will try to avoid any bruising or hurting and damaging the superficial temporal artery. This superficial temporal artery will be connected, of course, with the supraorbital one, with this horizontal branch. And if my patient fall, up, you see this first glabellar line is the location of the supratrochlear artery. So today we will not inject the forehead, but if you have to correct the forehead concavity, you will have to be deep into the bone here, because these vessels up to this security line, up to 2 centimeters, they are already superficial here, and here they are still deep. So here we have to be very deep into the bone.
Thank you very much, Nabila, for your patient assessment. We are looking forward to see the live injections. We are sure that it will be very interesting. And now we are moving to Paris to look inside the human face with Dr. Trivedi.
Thank you, Ludmila. I hope you hear me well. Welcome to the anatomy department of the medicine faculty in Paris. And I'm here with my two friends, Alexander Imanilov, plastic surgeon, and Gisela Lamila Criollo, plastic surgeon too. And they did the preparation of this cadaver yesterday. So I want to refresh your anatomy. And for that, you know that we will have layers, and for Teoxane, safety is the first word when we do injections. So my purpose today will be to open each layers of the face, because we know that there is no safe area in the face, but there are safe layers in the face where you can inject safely. So first we will lift the skin slowly. And as you can see, if we just pull the skin downwards, and if you are looking to the superficial dangers that you can see immediately in front of you, you can see first an artery that Gisela Nabila told you. It's the ascending branch of the chin here, as you can see here, going up, so it's superficial here. And you have to understand also that you get some branch here that could be superficial. We will see just after, when we will remove the superficial fat, and you see some branch in the superficial fat of the lips, and the other area where you see superficial danger. If we are zooming a little bit in this area here, you can see that is the angular artery of the face that you can see just here, that is far away from the tear trough that is here. This artery is in the nasojugal groove. If we go up, we remove here the fat, and the dangers will be superficial. And here, if we go to the temple, and we zoom on the temple, you can see another danger here, that is the branches of the temporalis artery. And if I lift a little bit the fat in this area, you will see just under the thin layers of fat above the fascia here, you see the arteria temporalis superficialis that is here. That is a big artery, and the other danger in the temple area will be deep in the muscle and not in the bone. So if we dezoom and we go on the profile, I will lift the fat. And you can see, if we stay a little bit like this and we dezoom here, you can see very well in the fat all the path of the artery superficially. If you have to draw a line, we can say that from the commissure to the lower part of the face, the main dangers are deep, unless in the anterior part where the danger are superficial. And above this line, the commissure line, I call this line the zygomaticus major line here. The vessel will become superficial, I will show you, until the top of this area of the glabella become deep until 2 centimeters, and will become again superficial. So you see that we have a deep danger area here, superficial danger area until here, and then deep danger and superficial danger. And here in the temple you see the artery. So we will move the fat down just to show you now the deep layers. and I will show you the main danger of the face, that is the fascial artery that you can see here. If we focus, if we zoom a little bit on it, the fascial artery is easily palpated here at the bottom of the mandibular line here, in a small depression of the bone, and this depression is just at the front of this muscle here, that is a strong and wide muscle, that is the masseter. This artery, you see, has a big diameter. This is the real diameter of this artery. We fill it with silicone to get this diameter, and this artery is going up. This is the DAO here, the triangular muscle, and you see that this artery that is deep is going under this muscle here, if we dezoom a little bit, and then will become superficial here. And this artery is in 80% in the nasolabial fold that you can see here. So this artery is going along the nose, giving the lateral here artery, if we zoom a little bit on it here. So this is a branch of the external carotid and the fascial artery. And then we go up along the nose, and you see very well here your angular artery, with the diameter of this artery very superficial. And this artery here will go deep and will anastomose with other branches. If we are going to the fat and we dezoom a little bit, you can see here, if we dezoom this plane and we get the full plane, you can see another artery very well, that is here, your transverse artery of the face. So this artery is below the zygoma. The zygoma is here, and you see that these branches are very, very superficial here and above. And here you see a specific things here. You know what is that? That I can pull on it, as you can see here. This is the Bicha fat pad here. And you see just above the branch of the fascial nerve, and you see also the parotid duct that is just here above the masseter muscle. And you get, if you dezoom a little bit here, the deep fat compartment where Nabila will inject it. And if we zoom a little bit to this area here, and we go face with the camera, you will see here, if we zoom on this area here, you see the infra-orbital branches of the infra-orbital pedicles, and you see that all these little branches here are superficial and mainly medial and inferior to the foramen. There is no branches going up here. And the last branch that you can see if we are looking just here, this is the zygomatico-facial artery here, with small, very tiny branches, so in the superficial fat also. So to summarize, if we want to know very well our anatomy, we dezoom and we go on profile, we can say that we have the deep dangers until the pass of the zygomatic here. So everything here is deep unless the chin. Then if we go up from the zygomatic muscle, the fascial artery will be here, or will be in the mid-cheek groove like this. So above the mid-cheek groove, you see there is no big dangers here. And this artery will become superficial also in the nose, as you can see here. If we zoom on the nose here, the vessels are superficial, and this is a big mess here. This is the area of the most dangerous in your face, because this is the area where you have vessels from the superficial layers to the deep layers, with this branch here that is the nasal artery and is coming from the ophthalmic artery through a connection that will be deep under this muscle. You see the connection, if I pull a little bit, going deep in the orbit, and you can see the vessel. And this is why you have a blindness if you touch one of these arteries, and the HA will go backwards to this artery. So here you have a good view of the anatomy of the face. And now I will let Nabila start with the mid-face and the peri-orbital area, and we will follow her after, showing where is the product that Nabila injected to her patients. Nabila, it's up to you.
Thank you very much, Patrick, for your brilliant explanation. Now we know everything about dangerous and more safe areas. So, and now we will teleporting to the Morocco once again. Nabila, we are here with you.
Thank you, Ludmila. What a fantastic dissection, Patrick. It's amazing. Now I can have this projection in 3D on my patient. Each time I inject, I follow this anatomical danger. I try to imagine these dangers on my patient. So let's start. We said that we will start by the mid-face with the multi-layering technique, and my entry point is located under the zygomatic arch here, very superficially a micropapilla. My other entry point with the cannula for the tear trough will be at the intersection between the tear trough and the palpebromalar groove. So I will use the lidocaine with epinephrine for all my entry points. Then I can see the whitening effect and see where should be my entry points. For the mandibular angle, I will use also my index and my thumb like this to locate the posterior border of the mandibula. And this is a way to be symmetric with the other side. So another entry point, just superficially. We said that we will inject also in the pre-jaw area. So my entry point will be more medial like this. And that's it for my entry points, because here in the temple I will use a needle technique, so I don't use local anesthetic for the entry point. So to answer again to the question of the mid-face, yes, I use a multi-layering technique, because here I will go straight to the fixed and non-mobile deep fat compartment to restore the support, and then from the same entry point I will inject in the superficial layers that are mobile, and that will be with RHA4. But first, the deep support will be done with Terusan Ultra Deep, and here I plug the 25 gauge cannula with a length of 15 millimeter. I just stretch the skin to open my pre-hole, and then as I want to inject in a deep fat compartment located here, the medial souff, and here is the lateral souff. The limit between both is the vertical line of the face, so I will pinch all the skin and the smooth. You heard the click of the zygomaticus ligament. I turn my bevel up. I'm on the bone, and my patient can tell you, and the tip of my cannula is on the medial souff. So I ask my patient to look forward, to look up. Then you can see also the improvement, the better improvement. Here I injected 0.1 ml. Zoom, please. And you can see already the lifting effect that I have with 0.2 ml of Terusan Ultra Deep in this medial souff. Here, a 0.3 ml in total. So I don't go out with my cannula. I just withdraw change the angle, and go to the lateral souffle. Touch the bone, place my bevel up, and inject 0.1 ml on the lateral souffle. Can you hear me? Maybe we lost the connection?
Yes, we can hear you.
Oh, okay.
We can
And
see you perfectly.
we lost the image on our screen, that's why. Look, Ludmila, I will go now in the deep medial cheek fat compartment. So I just change the angle again. And here I don't need a lot of product. I will inject only 0.1 here.
Can you show us where is the tip of your cannula?
Here.
Exactly here, in medial.
Yeah. So I'm lifting my cannula. You cannot see it because I'm deep. So I change the angle, and to remember that we need to enhance a little bit the lateral cheekbones. First to lift the jaw, but also to correct the asymmetry. So now I will go on the lateral cheekbone with some small boluses of Teozel Ultra Deep here, 0.1. I slide on this numbed area. I use Teozel Ultra Deep because it has the highest G prime property and of the range. So I want to restore the support, so I need a product that will give a nice projection, 0.1.
Can you show us now where is the tip of your cannula? How far?
Here.
Okay, yes, thank you.
If my patient smile, you will see a demarcation. Smile, please. You see? But
Yes.
now my last bolus is here. So don't forget to, so don't forget to go until the hairline. Now the tip of my cannula is here. Not, in order not to have this demarcation when the patient will be smiling. So this is why I'm using a long cannula of 50 millimeter. Because I want the lateral cheekbone to be totally improved and not only the inferior one. So you can
How do you
also,
think, Nabila, can we work with the same technique but using needle? Is it possible?
yes, it's possible, but you will maybe bruise more. And my advice is then to use the 25 gauge needle that is inside the blister of Teozel Ultra Deep. Because it's a long one, so you can use it from the same entry point. It will be long like this, so you can have the same technique, but use a long needle then, not the 13 millimeter. So now I'm modeling my product.
Do you feel the product under your fingers?
I feel that I'm moving it, but I cannot palpate it because it's deep. So let's sit her to see the face. So now you can see that we have a better projection already in the mid-face.
Yes, we can see it perfectly.
Also, the teeth trough is less appearing than the other side. And if I show you the patient on the 3/4 view, yes, you can see that we achieve like a highlight effect in the lateral cheekbone. But it's not finished because we need also to lift a little bit more and to get a high definition of her mid-face with RHA4 from the same entry point.
Do you use always RHA4 for the superficial fat compartments?
Yes, Ludmila, it's my favorite product for volumizing the dynamic areas. Look here, I'm stretching the skin, and I don't use other products for the mid-face in a superficial area because I'm not afraid to inject so superficial. You see how I am superficial? Sometimes
Yes, we can see the cannula.
you see, sometimes we have some mid-cheek groove here that are like a star, so I can make even a decision with my cannula and inject that superficially with RHA4. So it's a product that will mimic the natural HA that we have in the skin, and don't be afraid of being superficial because it will not be visible, it will not be palpable. Of course, I will model it and palpate it at the end of my injection, but after 2 weeks, the patient cannot even feel that she has a product injected under the skin. So now I stretch the skin, but my limit, remember, is that I'm not injecting on the nasolabial, nasojugal fat compartment here. I don't want to increase the volume already in this fat compartment. So I'm using a fanning technique with the bevel up. And
What quantity of product do you apply for one threading, more or less?
I would say 0.025. Here I injected 0.3 ml of RHA4, and I did like 10 lines until now. So it's mostly this. So a little bit here.
What about infraorbital fat compartment, superficial one? Do we afraid of it when we're injecting superficially? Nabila, can you hear me? We will wait a second. It seems that Nabila can't hear us. So those was superficial injections with RHA4 in the superficial fat compartments, just in case of multi-layering technique. Deep one was ultra deep, and the superficial one was RHA4 as dynamic filler. Nabila, we can't hear you. Please come back to us. Okay, we are still waiting.
Yeah. Just 1 minute,
Yes.
please.
We can hear you now? Yes, we can hear you, Nabila.
We need to replug the mic. Sorry, we have some issue with the mic.
Oh, okay.
Yeah. I tried to use the sign to tell you just 1 second.
Yes, I understood. Thank you. Nabila, one more question. When we are injecting superficially, are we avoid injecting into infraorbital fat compartment? Superficial.
Here you see, Ludmila, I was injecting in that direction,
Yes.
and also here. That was my lines. I was not injecting upper here. Here I will be using in the infraorbital area, I will be using now the deep injection with Total Density 2, which will be in a deeper layer, not in the superficial one. I have the whitening here of my entry point area, so it doesn't bleed. And here I'm using Total Density 2, but you see with the short cannula that would be more precise. This is the 25 gauge cannula with the 38 millimeter of length. And I use the length of my cannula to locate the position of my point at the intersection between these two lines. So now, yes, I'm avoiding the superficial fat compartment, and already here we know that it's lowering in the face with the aging process. So I turn the bevel up.
What will be the depth of your injection now with the density 2?
Now I'm going straight to the bone. I cross the orbital retaining ligament. I ask my patient to look up, and then we can see better the hollow that she has. I first inject 0.1 ml of Redensity 2. I model the product. I sometimes use, like Patrick is doing, an anterograde technique that push the product into the T-trough under the muscle. So you see I'm on the bone. If I lift my cannula, you cannot see it. I'm following the direction of the shadow of the T-trough. And since we have lidocaine inside the product, I know that this area is now numbed. I just take my syringe as a pen. I slide on the bone and I can inject another 0.1. In fact, I'm not looking at my syringe. I see the immediate lifting effect that I have. Now the tip of my cannula is here. And then I can inject a third bolus a little bit more medial here. And my patient is perfect and she's so brave.
Tell us, please, how far we can go with our cannula to the internal corner of the eye.
I can go with my cannula until the muscular attachment of the orbicularis oculi muscle will allow me. You see that now I cannot go more with my cannula. And sometimes we have some small depression at the inner part of the T-trough. So what I do is I withdraw my cannula. I go more superficial here. It's the only area where I can, with caution, inject a low quantity of Rivin CT2, very superficially like this.
Yes, we can see perfectly.
And then I model it. So I model with rolling my finger from down to up. I don't push on the product into the bone. And I can easily spread it. And I can tell my patient that the result will last up to 2 years, sometimes more. And you can see already the difference between the T-trough and the lip-cheek junction.
Yes. What quantity of product did you inject?
I was injecting 0.25.
Great, thank you.
Right. So my patient will look up here. Zoom in, please. Zoom, and then you can see the better improvement.
Yes, very nice result.
Let's go for the lip-cheek junction. From the same entry point, I change the direction, I press again the ligament, and now she will probably hit me because I will slide on the bone again. But now I will not inject boluses. Look, Ludmila, I will be injecting retrograding lines and intergrading lines. I try to create a pocket with my cannula. I try to make a hydro dissection with my Rivin CT2 into the lip cheek, palpebromalar groove area, because the skin is especially thin in this area. So I even with this soft filler, which is a mix of cross-linked and non-cross-linked HA, even with that, sometimes in very thin skin, you can have some visibility of the product.
Are you still under the muscle?
Into the bone, always.
Okay.
So now I spread the product and I can see that I still have a touch-up. And you can even with this precise cannula also inject under the lateral, the frontal ligament in some patient that wants to lift a little bit the eye. So we can go straight to the ligament and your cannula will be stopped, you see. I cannot go more, I'm under the ligament, and place a micro drop of product under the ligament.
Yes, this technique gives a nice lifting of the corner, yes?
We still have just the transition between both areas, so I go perpendicularly again into the bone. Look up, please. So the patient has to be really well seated at 90 degrees if you want to treat perfectly the T-trough, and the eyes has to be open. So now I injected 0.7 ml for the total infraorbital area. So let's see again. Sit, please.
Yes, we can see an improvement in the periorbital hollow. It looks great. Really very fresh look of the patient, yes, after this procedure.
You know, I don't want my patient to have a looking down result, so I just want to refresh this area of shadowing, like here, and to restore the volume that she had before. I know her for several years, so I know exactly where was the volume when she was younger. So I'm just refreshing and restoring the volume. Can you still hear me, Ludmila?
Yes, yes.
Because sometimes we lose the picture. But you know, now that I enhanced the lateral cheekbones, you see that the temple is looking even more hollow than it was.
Yes, for sure. We need to feel it.
Yes, we need to feel it, and I like the technique that Patrick has described in 2010, you know, the gunshot technique, and he described it with a long needle. This is the needle that you can find in Teruzel Ultra Deep Blister. It has a 25 millimeter of length, so it's very important because as Patrick showed you, you don't have only the superficial temporal arteries here, but you have also the deep temporal arteries that are running inside the muscle. So if you use a short needle, you will maybe not reach the bone, especially in this hollow temple. Your needle will probably stay into the muscle, and then you are dangerous. So look at the difference. This is the 13 millimeter needle, and this is the 25.
Yes, we can see the difference.
So if we palpate this artery and we avoid the vein, so we can inject here, look at the 13 millimeter, and here you can be inside the muscle, and with the 25, you can work with it safely. You will see the lifting effect, and also you can use it as a cannula. So you see I did 1 entry point. Here I'm using RHA4. I know that Patrick loved to inject also Teruzel Ultra Deep in this area. What I did before, I didn't show you, but my bevel is down, and with this angle I tried to reduce again the risk of hurting or injecting in any deep temporal arteries that we know that it has a connection with the lacrimal artery with the internal carotid system. So here I can inject then. I'm into the bone. The question was about the aspiration. So Ludmila, you will never see me aspirating.
No, not yet. Can you explain why?
Yes, Ludmila, I don't aspirate because of because it's if you regarding also the literature, you know that you can have only 33% of false negative first, and also that when you aspirate, look, if I aspirate here, I need to use my other hand to aspirate. So that means that my needle has already moved. So maybe at the beginning I was not on a vessel, but when I moved, I was in the vessel. The other reason, especially with the high viscosity product, high viscosity product, if you aspirate with only the air in the needle when you have not injected before, you can have some bleeding in your needle. But when your needle is filled with HA, especially a cohesive product, you will have to wait 10 minutes before having any product inside, any blood inside your needle. So look, I just modified the Patrick technique because now I like to use multiple small boluses everywhere. So you see me changing the direction. When I change the direction, I'm not injecting. When I'm sure to be on the bone, then I can inject. And here I injected already 0.3 ml in total with small boluses of 0.1 each time.
So you are moving your needle in different directions, yes?
Exact.
Now
Now
you put small boluses to
yes,
fill this area.
yes. You see, I change the position. I go to the remaining hollow that I can see. And now I already injected the 0.4. No, yes, 0.6. I change the direction of my needle to go to the lowest part, and you see the need of a long needle here.
Yes.
0.1, another 0.1.
How do you think? Is it painful to your patient or no?
Tell us, Linda.
Medium.
Medium, she said,
Medium.
because of the lidocaine we have here. So look at this bump. I will just model it, spread it like an implant. It was injected under the temporalis muscle, so you know here, and Patrick will show you that we have no risk of migration when we inject under the temporalis muscle.
Very nice. And we can see the lifting of the lateral part of the brow.
Exact.
Yes.
But we may have the piece sit, but we can see the result. I still have a 0.2 ml. Usually I use one syringe by side when I inject the temple. So look, we don't see anymore the visibility of the temporal crest, supraorbital margin, and zygomatic arch. We have hidden this contour projection of the bone, but I just need a small touch-up here. And yes, it has opened the lateral brow.
Yes, very much.
And it's now for me in a better harmony with what we have done on the lateral cheekbones.
Exactly. Yes, we can see it perfectly.
And this lateral cheek injection we did before has also lifted a little bit the jaw compartment regarding the opposite side.
Yes, in comparison we can see it too that the line of the lower face is better.
So let me just add a final touch-up just here at the last area.
And we can see also the improvement of the nasolabial fold from this side.
Exact. Zoom out, please. Because we worked on 2 layers. Yes, you see that here exactly. We have the shadow of the nasolabial fold. And here no. Let's see the result on a dynamic way. Please smile.
Great, very nice result and very natural.
And please give us a kiss. And you see that the product is following the movement of my patient.
Yes.
So, because she's super brave, I will show her in the mirror to relax because she doesn't know what I did. She just feel a numb area everywhere. So maybe she thinks that I injected huge amounts of product, but in fact I injected only show me please, 0.8 ml of Theosil Ultra Deep for the deep fat compartment and the lateral cheekbones, 0.4 ml of RHA for the superficial compartment of the face, 0.7 ml of Theosil Redon 52 for the infraorbital area, and 1 syringe of RHA for the temple.
Thank you very much, Nabila. It is a great result, really. You are perfectly on time. But now we will move to Patrick again. So see you.
Yes,
Patrick,
so
can you hear us?
do you hear me?
Yes, we can.
So if you are looking to this area where Nabila did the injection, she did the injection in the mid-cheek in a multi-layering technique. Then she went to the teardrop that is just here with the Redon CT2, and then she went with the deep injection
in the temple. So first, I will show you the multi-layering technique in the mid-face, and just for cadaver reason, I will just inject first with my entrance point, like Nabila, in the superficial layers. So I pull on the skin, and I will be in the superficial fat where you see there is not a lot of vessels. So if we move the fat and we pull the fat downwards of the cadaver, you see that my cannula is in the superficial fat here. This is the tip of my cannula here. And if I push a bolus, my injection will be of my superficial injection will be in the first layer of the face, that is the superficial fat layers. Then, if I pull down these superficial layers, you can see here the deep fat layers sticks on the bone. And how you can imagine on your patient the different deep anatomical structure. If you draw a line here, a vertical line of the face, you divide the face into medial and lateral, and here you get the medial souph, lateral souph, deep medial cheek fat, medial and lateral, just above the zygomaticus major. So the second injection of Nabila was going, deep on the bone, sliding on the bone, going up until she reached, here, as you can see, the medial souph. Then she moved laterally to the lateral souph, up again. As you can see here, my cannula is in the lateral souph. Going, if you want, to the zygoma, and going also deep here. The tip of my cannula is here. If I inject, you will see where is the deep injection. If we focus on it, she did small boluses here that you can see in blue. And the last point, it was, if we dezoom a little bit, but not too much, she was in the deep medial cheek fat compartment that is just here. So 2 layers of fat, 2 aging process, 2 layers of injection, and 2 products. Then she moved to the tear trough. The tear trough, if we dezoom, go a little bit up, she was just an entrance point here. And she goes, and if we go face with the cadaver, you will see that my cannula is sliding on the bone, in the bone origin of my muscle here. You can see my cannula sliding on the bone. And if I inject the blue HA of my syringe in this area, you will see, if we zoom a little bit in the tear trough area, you will see here the blue HA that you can see here. If we go a little bit down, you can see the blue HA that is just inside the bone origin of the orbicularis oculi muscle, and this is where is my injection. We go now on the profile, and I will do the gunshot technique with the Nabila version. So if we go to the temple and zoom a little bit on it, first you have to understand that the only safe injection you can do in the temple is the gunshot technique. And it's easy to understand because the main dangers are superficial, as you can see, and the deep dangers are inside the muscle. So if you are on the bone, you are safe, or you have to review your anatomy. So you put your needle straight down here, go on the bone, touch the bone, sliding a little bit bevel up, and I will do an injection of products here. I did an injection. Then Nabila move her needle like a cannula technique, just to be on the bone each time, bevel down. And if I show you what happens, with this injection, I have still few seconds, I will show you. I will open the muscle here, like this. I will take a pinch, and I will show you where is my products. My products will be, look at this temple here. You see that my muscle has a stick and a strong adhesion to the bone. And if I lift this muscle here, you see here the artery. If we focus on it, you see here the artery inside the muscle here. You see this artery here. But my products is not here. My products is on the bone, as you can see here. You see the blue here? You see very well the blue. And this is a safe injection because you see that the blue is on the bone and the artery is inside the muscle. Thank you very much.
Patrick, we have one more question about the arteria transversa. Can you show where is it situated?
Yes.
Should we be afraid of it during the injection of midface?
So look, we have a perfect view here. If we zoom a little bit here, where is my pinch? You see here, because I put my artery on this side, but normally this artery here, I will take it like this. I will take a scissors. And I will show you where is this artery. So this artery will be superficial here. You see, this is my transverse artery. But because I put the fat, on the other side, normally this artery that you can see here is like this. This is the transverse artery of the face. This artery here is below the area of injection of Nabila and is just superficial in the superficial fat that you see here. So this artery is below the zygoma, coming from the temporalis artery that is just here, as you can see. So this artery stops below the zygoma and will run under the zygoma, superficial, and will finish here. As you can see, if we focus on it here, you have here a lot of anastomosis between the superficial layers of the transverse artery and the deep layers coming from the fascial artery here. So this is not a danger for you because it's superficial and moreover away from your site of injection, and moreover you use a cannula for the superficial plane. I hope I answered to the question.
Yes, thank you very much. It was a beautiful dissection. And then we are switching to Morocco again. Nabila, are you here with us?
Yes. Can you hear me, Ludmila?
Yes, we can hear you and we can see you and your model.
So, do you remember that her base zygomatic width was much longer than, wider than her begonial width here? So now I want to restore the proportion by enhancing the mandibular angle, and it will help me to well define the jawline and to pull back the jaw. So I already have my entry point. I can see a whitening here area. I redo again with my index and my thumb here to locate the posterior border. And Patrick will show you that here in the mandibular angle, we don't have any danger deep or any danger superficial. So I can work on a multi-layering technique also here with, again, closal ultra deep for restoring the support in the bony structures. And for that, I'm using a 21 gauge needle for two reasons. First, it's a long needle. It will not be painful. It's a 21, it's a little bit, but here, as we have numbed the entry point, you see that I need also here a long needle to reach the bone. You can stretch the skin here. yeah, and pinch it. The second reason is that it's already making for me the pre-hole for my 22 gauge cannula. So here, it's just a habit, but I'm always blocking the flow of any vessel that can come. But I know that in the mandibular angle I don't have. But this is a thing that I will do also in the chin or any other area where I need, like when I do the nose, for example, to pinch the flow coming, the blood flow. So here I injected already deep into the bone 0.2 ml.
Do you inject one bolus or multiply boluses?
Multiple boluses of 0.1. You see me moving a little bit my cannula, my needle,
Yes, we can see.
and I'm injecting only when I'm into the bone. Here I injected already 0.4 ml. So let's see the projection that we get.
Yes, can you compare with other side, please?
Yes? You see the projection at the angle?
Yes, it's very visible.
So here and now.
Yes, nice result.
So when I was with my 21 gauge needle, I injected in a perpendicular way. So I have a tunnel in that way. So now I know that with my cannula, I switched for closal arche 4, and here I need to inject with the rigid cannula, first for safety, but second for being more precise. And here it's a 50 millimeter of length. This is a 22 Steriglide cannula, and you see this black marking show that the bevel is up here. So what I do is that what I call the straw technique. I'm using the tip of the cannula to bend my cannula. So why I bend the cannula? First is to be more comfortable on my injection, to avoid any earring or hairs. And the second is to do like Patrick was describing for hands rejuvenation. He was bending the cannula in order to be the most superficial possible. So here, let me see my pre-hole. I just press the vernish and immediately go superficial. So here I'll say that I can use two superficial layers, one medium deep and one very superficial for the definition. And my cannula will stop where the jaws start. So now I'm lifting my cannula, and you can see that I'm not that superficial. Of course, I'm not deep because I want to avoid the facial artery. I'm on the subcutaneous layer, but I'm medium deep here.
Yes, we can see it perfectly.
And that is the only area that you will see me injecting quickly, because usually I'm a slow injector. Why I will inject quickly is to make a thread, like a spaghetti, and not like a ball and the line, a ball and the line. And even if you have a ball and the line, you can model your product and RHA4. The product will stick together and you will have a nice line. So here, with my retrograding line, I was injecting 0.3 ml for this first line. But here, I will better define this area, and I stretch more the skin in order to stay more superficial, checking the direction of my cannula. You have the pre-mesenteric ligaments that you can feel the resistance here. And now you see that I'm more superficial than I was before. Again, stretching the skin, quick thread, modeling the product, and this is how I can achieve a better definition of my jawline.
Yes, perfect line.
So don't be afraid to stay very superficial with RHA4. You will see that after a few days, these bumps, and even now, there are no more visible. In a female patient, I open this angle at 120 degrees, not like in a male patient where I will be injecting in 90 degrees with maybe a larger bolus of total ultra deep into the mandibular angle. So let me just cross again the dermis. Give me 21 gauge needle.
Nabila, can we use the ultra deep for the superficial injections?
I sometimes do it in a male patient with very thick skin, but then I'm medium deep, like I was doing my first line here. But usually, even in male patient, I use RHA 4 in the superficial layer. So look again here, I'm superficial with an angle.
Yes, we can
And I lose a little bit of product into my entry point. So some of my patients like to have a very well-defined angle also. So this is another tip. Look, I place my index and my thumb like this. You see that with the 22 gauge cannula, you cannot bend your cannula when you have a resistance. So look here, zoom in please.
So you are at subdermal level, yes?
I'm a subdermal level, and I will do like a short fanning technique, touching like my cannula is kissing my finger. You see, I have to touch my finger to have this clear-cut angle at this side. So final touch up here, and modeling. You have to push on the pre-hole not to have a product going outside. Just the last touch up under the pre-hole. Ça va, Elena?
What quantity of product did you use totally?
So I injected 0.4 ml in at the angle D of total alpha deep, and superficially I use all the syringe of Teozel RHA4 in the superficial layer.
What is the average quantity for women and for men when you are treating the lower third?
So for a female patient, I usually use 1 syringe and a half for jawline and angle, 1 syringe and a half, half, and 1. So it's 5 syringe for a female patient. In a male patient, it's an average of 6 to 7 for all the lower face.
Okay, thank you.
So now you can see in the front of you that on this side she has like a S, like a,
Yes, we have.
like a wave like
We can
this,
see curves, yes.
curves, and here you don't see anymore the curves and you have a better defined jawline here.
Yes, we can see a perfect straight line.
And on a profile view, you can see that now we have these shadowings created on her neck also, so we have again a better definition. Once again, and here. So remember, we stretched the jaws up, back, and now we have to stretch it forward. We need to redefine the mandibular line here. To continue in the same line. For that, because she has a thin skin, I will be using Teozel RHA 3. My pre-hole is a 23 gauge with this direction because I want to draw first the mandibular line and then the lifting and filling the pre-draw sulcus. So
We have got some more questions from the attendees. Can I ask?
of course.
So, why do is better to use small boluses in the temple area, not one bigger bolus?
For me, it's a safety reason. We had some articles, but it was about the area of the supratrochlear artery, where the study of Kahn showed that we have an average of 0.085 ml of HA that can give blindness if the product migrates from the supratracheal artery to the central retinal artery. So it was an amount between 0.04 and 0.12. So with this average of 0.085 ml of product, we can have blindness. So this is the reason why now, especially in the upper third, I reduce the amounts of each bolus. I reduce the risk of necrosis or blindness. Especially if I lose my layer with my needle and I'm inside the temporalis muscle, I know that I can be more dangerous if I use large amounts in one shot.
And one more question, Nabila. So in your opinion, what is it better to use in the lower third, the hyaluronic acid or calcium hydroxyapatite?
Both are possible. Look, we had a nice result with the dedicated product for those areas with HA. Of course, both are possible. HA is filling and hydrating and also stimulating the collagen. Maybe hydroxyapatite, of course, is made for stimulate the collagen. This is the main maybe advantage. But look at this nice result with HA.
Very nice result, really.
I was pinching the skin between my two fingers in order to place the product between both. And I will show you again because I was speaking that I went just under the skin insertion of the mandibular ligament and placed the blade of HA there.
What quantity of product did you use to get such nice result?
Thank you. Let me show you. 0.3 ml for the line.
Oh, great. Very little.
Only the line you see has improved her lower face.
Yes, for sure.
But look at her lateral commission, which is drooping here. Now, if I push the jaw, you can see that would be my limit of injection. So from the same entry point, being superficial to avoid the labiomental artery, and to have a nice lifting effect, la lichotement. We will move a little bit the table up, please, and the camera. Yeah. Look now, I'm just under the corner of the mouth. It's that we call the lip flip.
Did you cross the corner?
Yes, I will show you again. This is the tip of my cannula. I'm on the corner itself. With RHA3, that means no risk of visibility or tyndall being that superficial, okay? So I will turn her a little bit. I tell my patient that this area will be probably bruising in the next few days because here we have a lot of small vessels.
So you are on subdermal level, yes?
Yes, look at my cannula, Ludmila.
Yes.
Here I'm superficial with the bevel up, with the limit of the posterior border of the DAO. I don't want to increase the jaw more. You see, I will just end my cannula, the tip of my cannula, in the marionette line itself.
Yes, we can see.
Retrograding line, homogeneously. And here I injected half of the syringe already. So I change the direction. And I stay superficial in all the pre-jaw, this triangle area.
You just completely erased the shadow from this area now.
Thank you. So let me check with the frontal view. You see no more print here on the bone,
Yes.
and here a nice light coming into the preacher,
Exactly.
and no more jaw.
And the commissure is lifted too,
Yeah.
in comparison to the other side.
So if we look at her on a profile view, we can in frontal view here you can say that is enough. But if you see her on a profile view like this, we know that we will stretch again this lower face by projecting the chin like this. So I keep my patient on a profile view to see the level of my chin injection. So I will just make a simulation here, and if my injected point should be at this level, I let a drop of product, as you can see here, a drop of HA in the level. It's like a drawing that I made with my HA product. Here, once again, on the bone I use laser ultra deep, and once again with a long needle. So that will be my level of injection. So that means that I will use a medial bolus and two lateral bolus here, one here and one here, always located between the length of the nose.
And what about male drawing for the injection of the chin?
That is my landmark for male, the length of the lips, because I need to have a squared and larger chin in a male patient like this. But in a female patient, I prefer to have a more pointy chin, less large than a male.
Okay, thank you.
So when I have this fold between the two lobes of the chin, especially in male patient, I keep it. I inject only in a deep layer. I don't do my retrograde in line with RHA4 in the superficial layer. So here she doesn't have any fold in between, so we just want to give some light and some reflection in her chin like this. So for that, you see with my non-dominant hand, I push and block the flow coming from the ascending mental arteries, and I look at the bevel of my needle, I turn it down. In the midline, we know, and Patrick showed you already, that we don't have any ascending mental artery in the midline. They are always bilateral, and here running inside the mentalis muscle. Usually in the studies, we find that the ascending mental arteries are lateral to the midline, of course, but one is always bigger than the other. But I'm used to block the flow even in the midline for that. So here for this first bolus, I have injected 0.3 ml. She's very symmetric on her chin, so I will use the same amount of product. Please,
What is the largest quantity of product that you can inject in the chin on the deep level?
For me, it's around 0.3 by bolus.
Okay.
So now, two lateral bolus, one here and one here. I keep on pinching on the mandibular bone. Now I can feel that my needle is a little bit eroded, so I will change for another needle. Here I injected 0.2. So 0.1 by 0.1 slowly. My assistant will change the needle for me. Change l'aiguille, s'il te plaît.
How do you think, Nabila, can we use the cannula for the deep injections on the chin?
Why not? But yes, if we do that, then we can use one single entry point in the midline.
Okay.
So maybe we can do a pre-hold with the 21 gauge needle and go straight to the bone with the cannula and change the layer. Why not? I never tried it, but I will do.
What
But I
kind
found
of
out that
cannula?
I will use here a rigid cannula because of changing the direction and sliding to the bone. My 25 gauge would bend.
Yes, I agree with you.
So I changed the needle, and my assistant has already removed the air from my needle, so it's already filled with HA. I will go straight and symmetric to the bone with the bevel down. Keep on pinching, and you can see the light coming in all her chin now.
Yes, we can see it perfectly.
Okay, so that would be enough. Remove, zoom out, please. You see? That could be enough, but let's see how my remaining RHA 4 will improve in a superficial layer.
Can you show us the profile of patient,
Yes?
please?
So now you see only light coming into her face and no more shadows on this side.
Oh, great, very nice.
Thank you. So let's see the superficial injection. It will be very, very superficial once again with the RHA4. Remember, I have a remaining product from the mid-face. So here I will be using all the length of my 25 gauge needle. So I just see where should be my entry point. So it should be here. And very subdermally avoiding the vessels and blocking the flow once again, checking that I'm very superficial. Just a nice highlight. Working on the superficial fat compartments of the chin. It was only 0.1. So you
Yes, we can
see,
see more light on her chin
more light.
now.
Je peux voir dans le miroir. Non, je prépare l'aiguille grise. L'aiguille grise. Elle me le fait, l'aiguille grise. Tu peux me donner l'aiguille grise? So let's see with a zoom out. The total result on this side.
Yes, great result.
Thank you. Now the lips, Ludmila.
Yes.
I would be injecting very superficially because Patrick have showed you how the superficial labial arteries are crossing the orbicularis oris muscle and going on the submucosal side here. So you can also palpate it between two fingers. That is a big artery and you can feel the pulsation. So here, because I have the stretch property of the product that can allow me to inject very superficially to resist to the movement of the lips, like here with the RHA2, which has a high stretch property, it helped me to be safer than with the deeper injection. Here I would be injecting the vermilion border for the contour, but also hydrating and giving a slight volume in the supra orbicularis oris muscle area. That means above the muscle. So for that, I will ask the patient to open the lips. I keep on pinching the lateral commissure here. I use a 27 gauge needle for my entry point. I don't want a big hole in my lips because it's very sensitive and it will swell. And here I'm using a 27 gauge cannula with the level up here. I decided to use only RHA 2. I could use RHA Kiss also, because I just want a natural and slight volume. So look at the level of my injection.
Yes, we can see perfectly. You are very superficial.
I do like I want to cross the skin here, but it will not cross. It will not go through the skin. But I have to be that superficial. Turning the bevel up, I know it's very sensitive in the lips. I keep on pinching, and I do a quick retrograding line.
Nabila, we have got 5 minutes for each area.
Okay? So the contour is the more sensitive.
What quantity of product did you use for the contouring the
It was
lips?
0.1 ml for the contour.
Great. Do you often work with a cannula for lips?
No, Ludmila, I use sometimes in younger patients or with patients with very constricted lips, with the lack of eversion. I use the noodle painting technique. You see how I am superficial?
Yes,
As
we
I
can
said, for
see.
safety reason, but also I want to stretch all these lines that she has on the upper lip. You see that
Can you ask your patient, is it painful for her?
Linda, is it painful? Tell the truth. On 10. It is painful. Tell me. Yeah, in the beginning.
Only in the beginning. Okay, thank you.
Yeah, because of the vermilion border, it's quite superficial, and you know that all the papulas or this very superficial injection are more painful than the deepest ones. But now that she had the lidocaine already, she doesn't feel anymore. So sometimes I use nerve blocks for the lips, but it will open again. Open. It will change a little bit the disposition of her lips. She can be quite asymmetric during the injection.
So now you are more close to mucosa, yes?
I'm always on the dry lips, not on the wet lips, on the mucosal side. But look at how I'm superficial. I'm approaching the mucosal side, but I'm very superficial here. Just stretching the skin, the lips, the red lips. And I'm not afraid to have any visibility here. So look, Ludmila, when I want to also contour the other branch of the V, I cross the midline, and because I'm on the good direction, I will contour the other branch of the V like this,
Oh,
with
great.
a small retrograde, and that's it.
Very nice. Yes, we can perfectly see the result.
Mm-hmm. So I just maybe have time to show you the lower lip.
Yes, we have got 2 minutes more. Please, we want to see the lower lip too.
Okay, so please hold needle, please. Open the lips. So here I use one single entry point for the total lower lip. And, yes, sorry. Please hold needle again. I was not that deep.
So what other products can we inject in the same technique from the Imperial collection?
I use RHA Kiss, and I use RHA 3 when I want to have more volume. Open please the teeth also. So I ask my patient to open the teeth and look at how I'm holding my patient. Zoom out please, just to show.
Yes,
Okay,
show
my
us.
arms is just, I'm, zoom out. Yeah, you see I'm holding my patient.
Yes.
Like I'm hugging her from here, asking her to open the lips, zoom in. And once again, being very superficial. It's like my cannula is far, that is a little bit more painful. Okay, look, I'm very superficial. I'm already in the other corner of the lips, and I inject with a quick retrograding line once again.
And what about tertial kiss? In what technique do you use this product?
With the same technique, you know, that is the same properties than RHA2 that I'm injecting here.
Not RHA kiss, but tertial kiss.
Ah, sorry.
Yes.
Tertial kiss. I cannot inject it that superficial. You see here, I'm very superficial. I was using tertial kiss before, and yes, we still have patients that really wants visible volume. So for that we can still inject it, but I found that with the RHA3 I have already nice volume, and I prefer to not to have looking down result using stronger product for the lips. But we still have in our area patients that are asking for like Russian lips or big visible lips. So you see here again, I'm only on the red lip.
Yes, and superficial one. Thank you, Nabila. Can we zoom out a little bit to see the whole face now? And we will move to the Paris because Patrick is waiting for us. Great. Very nice result and very natural one. Can you smile, please? Can you patient smile? Yes. And to turn your head a little bit. Understand? Oh, great.
So this is the preferred view.
Very feminine one. Thank you, Nabila. It is a great result, and we are moving to Paris again. Patrick?
Yes, Ludmila. So here we are on the cadaver. I will do a multi-layering technique like Nabila did, you know, in the jawline area with the Texas technique. And then I will move to the chin to do the multi-layering technique. And I will finish with the lips. So here you have the superficial fat, you remember, with some superficial vessels here. This is why in this area, even if the main danger is deep, that is the facial artery, I will start with an injection like Nabila was doing in the superficial way, as you can see here. And when you inject in this area, I will inject a little bit, so here you will see the blue here. You see the blue coming, very superficial, and with my cannula. So I did my superficial injection with my cannula, and then I will show you that the blue was inside, as you can see here, if we zoom a little bit, was inside the fat here. So my cannula put the HA superficial to this area, to this line, and it will be the same for the anterior injection that Nabila did. Here, what you can see if we go and we zoom on the mandibular angle is that we have multiple planes here. The main anatomical element is here is the masseter muscle. And posterior to the masseter muscle, this white here volume is the parotid gland here. The parotid gland, when you are lying down, is going behind the bone, behind the masseter. But when you are standing up, sometimes the parotid gland is coming to the mandibular angle. And above that, you see here a muscle that normally covered here the masseter, the inferior part, but here it's a variation. The platysma is just coming like this above this element, and you have the superficial fat. So bone, masseter muscle, just at the corner a little bit of parotid glands, platysma sometimes, and fat. So when you do a deep injection in the masseter, in the bone origin of the masseter, that is almost the same than the temple or the same than the tear trough, your injection will be deep on the bone, bevel down, very safe. The blood supply of the masseter is coming mainly from the transverse artery of the face. So here, if I do an injection here deep under the muscle, you will see the inflation of my muscle here. And if I do a dissection, you will see that the muscle fibers are on the bone and stick on the bone, as you can see here. So it's a wide muscle, and you see where I injected here. It's on the bone where you see the blue here. That is just here. Okay. So this is the deep injection that Nabila did. Just 2 points. The what she called the fixed point of the lower face. It's where is coming the fascial artery. This is the buccomandibular ligament, and the outer anterior point is the mandibular ligament here. So the premasseteric ligaments here, the mandibular ligaments here at the posterior part of the DAO, and between these two fixed points, the jaw, that is the superficial fat here, is going down. So let's go now to the chin. So we de-zoom a little bit, and Nabila did a multi-layering technique, like here. So what she did a direct bolus injection in the chin. So here, Sasha, could you push the plunger? So if you push the plunger, you will see that the chin is lifting, as you can see here if you zoom. And what she did also is injection in a superficial way. If you are looking to this superficial area, this is here, as you can see, the fat. So if I push a little bit my cannula superficially in the chin, as you can see here, and you go just here, push, Sasha, you will see that my injection of blue HA will be, as you can see here, very superficial. And if I do a fan technique here, going here, you will see that if Sasha push a little bit more, you will see a second drop of HA. Stop. So you see, this is my superficial injection, and if I cut this area, so if I remove the blue here, and I cut the chin in 2 layers, you will see here, if I open it, you see here your superficial fat here, here the muscle here, that is your mentalis, that is a big one, if I open a little bit more, here, and just deep in the deep fat, if I open this deep fat, you discover the blue HA here, in 2 layers, in the deep fat, fixed on the bone, and in the superficial layers, in the superficial fat.
Yes, we can see it perfectly.
Just to finish, I have 1 minute. I will go face, and we will check what happened in the lips. So if we go face, I did the injection like Nabila did it in the cupid's bow. And if I open the lips, you will discover that the HA will be superficial in the cupid's bow in what the people call the virtual canal. So look here, you see very well the blue that is under the mucosa, and you see here, and I will show you, where is the artery here. You see here the artery that is in a submucosal position. So if you are going on the other side, you see the blue H shade here, and here you see my artery that I pinch. I will show you on the other side. So I will go on the other side and I will show you this artery here. You see here, this artery is coming from the lateral side here, going here, and cross the muscle to go under the mucosa here. So you see these arteries coming laterally across the muscle, and you see few small branches going up to the columellar artery. This is what I wanted to show you today. Thank you.
Patrick, we have got questions about French kiss technique, and we have got a time. Can you show us where we should inject the bolus and show this bolus if you can?
Yes, I will show you. So we are going back face, and we are going to the area where I injected. So if we are going to zoom on it, you see the different place where you inject. Look, in the center, you got this pink with a cross shape. That is your orbicularis oris muscle that reach the blue point, that is the limit of the vermilion between the white and the red dry mucosa. Then you have here at the center, but on the mucosal side here, you get just here at the junction between the red dry lip and the red wet lip, you get just here the artery. This is a small artery. And so the French kiss technique, I will do it with a needle, and I will take a red one. I will show you what I do with the French kiss technique. I put my needle targeting here this area. It means the area that is in the wet area of the mucosa, so above the artery. So if I do a little injection, very superficial here, you will see that my injection will be here. So to summarize, you get the classical injection that are, in the anterior part and in the dry red lip with the vermilion border and the Russian lips here and the Parisian technique here. You have here the most dangerous area, that is the junction between the red dry and the red wet lip. And you have just here where you inject when you are, doing a French kiss technique. You will tell me there is anatomical variation of this artery that you can see really well here. If we focus on it, you see this artery here. This is my artery. And if we focus on this artery, she could be 2 millimeters up or 2 millimeters inside the muscle. So the area of this artery, if I put a bolus on this area to show you where could be this artery could be just like this, like my deposit here. So it means that this artery could be in the muscle, could be in the junction here, or could be until this area here. This is why, during the French kiss technique, I put my finger here just to palpate the bump that will be above the danger. I hope it's clear.
Yes, Patrick, thank you very much. And tell us what product should we take and use for the French kiss technique?
For the French kiss technique, that is, in my point of view, an advanced technique, not for beginners. you will use RHA2, RHA KISS, or RHA3 because you will get 6 bumps under the mucosa, and you will have after to do a gentle massage to erase the bump very easily because it's a forgiven product, the RHA.
Thank you very much.
Thank you, Ludmila.
So we will not have any questions for now because we asked and answer all of them. Dear Patrick, dear Nabila, thank you very much for your amazing work for today. It was really beautiful and gorgeous, and we were able to get a lot of information and a lot of deep understanding of the anatomical approach. Thank you for all the attendees staying with us today to spend this great time. I hope that all of the information that you have got today will be very useful in your practice to get safe and beautiful results with your patient. So stay tuned and welcome to the Teoxane Academy again on the Every Hour webinar. Thank you very much.
Thank you so much.
Bye-bye.
Bye.
See you soon.
Bye.
See you.